I'm sipping a cup of tea. You can all join me in that.
Okay, sir. So I think we can start now. Um, Good evening, everyone. I, Ritika, and my co-host Zainab from Global Association of Indian Medical Students and the moderators of today's session welcome you all to today's panel discussion on the topic
But
Cancer Awareness
we
and
are there.
Prevention.
How many are there?
Yes, sir.
How many students would be there who will be joining in?
Sir, actually, this
Right now,
is,
I can see 3 only.
sir, they are all on YouTube. On the Zoom, it's just the hosts and the panelists. So
Okay.
they are all listening to us on YouTube.
How many are there? So will they be able to ask questions or?
Will be able to
Sir,
post their questions in the chat box. We will read out their questions to you.
Okay. We will not be able to see their faces.
that won't be possible, sir. Sorry.
Why Ritika? Why we not?
Ma'am, actually, we have over 450 participants.
Okay,
So,
good.
seeing everyone's faces would be a difficult job.
Okay, good work. Hmm.
Yes,
What happens these days because of Corona, everybody is masked. I thought at least
yes,
today we'll be able to see their faces without mask.
sorry, sir. Really sorry for that inconvenience, but they are all listening to us right now live.
Welcome. Let's.
Yes, sir. So, as Robert A. Washer correctly mentioned in his words, that an ounce of cancer prevention is worth a ton of cancer cure. So, today we are here to discuss one of the most debatable, yet one of the most favorite and highly needed research areas, that is cancer prevention.
Sure.
Rightly said, Ritika. Hello, everyone. I'm Zainab Iman. Today, it is a moment of great honor and privilege for us to have three highly esteemed and senior panelists who hold expertise in their respective fields and have taken out time from their busy schedules to grace this occasion and share their viewpoints with us. So, let me take a moment to introduce them. We have with us Padma Shri Dr. Rajesh Kumar Provat, who is one of the senior medical oncologists in India. Sir is the ex-director and CEO of Delhi State Cancer Institute, one of the premier institutes of cancer treatment in India. His specialty is clinical oncology with radiation and medical oncology. Sir has 50 scientific papers to his credit, and many of them have been published on online repositories. Sir, we are honored to have you with us.
Thank you, dear. Good evening, everybody.
Then we have with us Dr. Rudra Prasad Acharya, sir. Sir is an accomplished multi-specialist oncosurgeon with an experience of over 20 years and currently working in Batra Hospital, Global Cancer Care, and Rejoice Laparoscopic Center, New Delhi. Sir also has worked in Max Super Speciality Hospital, BL Kapoor Hospital, and Artemis Hospital, Gurgaon. His areas of interest are gastrointestinal, thoracic, uro-oncosurgery, sarcoma oncology, and limb salvage surgery. Sir, it's a pleasure to have you amongst us today.
Finally, we have with us Dr. Vinita Kumar Jaggi ma'am, who is the Chief Gynecological Oncosurgeon and Coordinator of Robotic Surgery Program at Delhi State Cancer Institute. She is also a fellowship holder from Singapore with 14 years of experience in gyne-oncology. Her areas of interest are translation and clinical research in gynecological malignancies. Ma'am also has numerous publications to her credit. Ma'am, it is a privilege to have you with us today.
Thank you, Zainab. Same here. Nice to be with you, youngsters. And a great show. Congratulations. All the best.
Thank you so much, ma'am. I would like to inform our audience that this panel discussion is divided into 4 segments covering the following topics. Segment 1 is about general cancer prevalence and its culprits. The second segment focuses on cancer screening and prevention. Segment 3 is a short one, which covers something about curable cancers. And the last segment emphasizes on the fight between cancer and common man.
For our panelists, although at a time one question can be presented to only one panelist, the rest of the 2 panelists are also welcome to share their views with us on the topic, because the more we learn, the better we become. So without keeping you all waiting any further, let's start our panel discussion.
So, we are starting with segment 1, that is general cancer prevalence and its culprits. It's my privilege to present the first question to Dr. Grover, sir. Sir, could you tell us the most common cancers prevailing in the world and India, and which are at peak levels in males and females?
Let me share with you some PowerPoint presentation to make forth my viewpoint before all of you to understand what the cancer incidence in different parts of the world is, how it is different in country. Then we later on point that why it is different and how it can be prevented or how it can be cured earlier. So I'll just try to present to you some global data which includes the mortality and the incidence. And I'd like you to pay attention on the incidence rates and mortality rates in different parts of the world. And then you will able to see the comparison that why in our country, despite the incidence being low, the mortality is very high, and why in some of the developed countries that despite the incidence being almost 4 times that of a country, still the mortality is less. So that means there is wide gap. I'll show you the graph which is from IRC. You see the blue lines and red lines, which is in incidence and mortality. You see the gap between the incidence rate and mortality rate between different countries. I'll just bring forth the slide. Yeah. Can you see the slide? Hello? Can you see the slide?
Yes,
sir.
So if you see the topmost, the USA data, you see the how much the incidence rate. It's almost 350 per 100,000 plus in males, and in females also is almost 300 per 100,000. And you see the red lines of mortality is almost in females is almost 1/4 of the incidence, and in males it's 1/3. And the bottom is India, which you can see that the difference between incidence rate and mortality rate is not much. So
yes.
although the number of cases, that the incidence rate, which is the upper line, is much less compared to what you see in other developed countries. You compare USA, European Union, more developed regions, you see from the top, gradually some descending line. So India is amongst the very low incidence rate, whether it's underreporting or if the incidence is actually low, we're still not very sure, because you know how sketchy a data is normally supposed used to be. But whatever data we have, on the basis of that, we have very low incidence rate, but compared to that, relatively very high mortality rate. So we have to do something. If we are fortunate enough to reduce and say have such low incidence rate, then why should mortality should be as high as what you see in the USA? You know, in USA, our population is almost 1/4 than what we have. In Indian population is 1/4, but incidence rate is almost 4 times.
Yes.
But mortality rate is almost the same as that in India. So this is something which we need to ponder upon and discuss. And here again, you can see the graph where we are showing the incidence is almost reaching 350 per 100,000 population. All these developed countries ranging between 250 to 350. Okay, this slide. This is then again from USA, Australia, Canada, almost reaching 350. Then we have lower countries like Costa Rica and Colombia, which is not so developed. The incidence rate is 200 and less. Then you have Japan, China. These are Asian countries. You say Japan is on high end again. That is, you generally see which are developed countries, they have higher incidence rates compared to those which are underdeveloped countries. The incidence rate is low. India again is at bottom. Again, I'm very skeptical about it, whether it's really which is incidence which is low, or data recording is not so good. And this is in the female. This again, Denmark is the top, then England and France and Spain, the developed countries. This is again females. USA, Australia, New Zealand, Canada, Colombia, Costa Rica.
उसको करके दोबारा करियो.
Hello, you said something. Somebody said something. And these are the Asian countries: Philippines, Singapore, China, Japan, then Thailand, India. Japan, you will find here the females and incidence is lower compared to what you saw in males. It was very high, because in males the stomach cancer is very common in Japan, but when it comes in females, everywhere in most of developed countries, the breast cancer which is, takes the highest leading the data. But in Japan, the incidence of breast cancer is lowest in the world, because generally these are frail ladies, not very heavy built, and that's why breast cancer incidence is low. But in males, because of the high salt intake, the stomach cancer is a little high. So in males, you have seen the incidence is almost 300 per 100,000, but in females, is coming to about 170 per 100,000. But India is still at the bottom. So we have relatively very low incidence of cancer, but this incidence is likely to. This was data from 16 when it was projected in times of India that incidence will rise by 25% by 2020, and we are seeing they are rising. And this about again 3.9 million cancer in 2016 in India. This 3.9 is the prevalence rate, not the incidence rate. So don't just very alarmed by this. Incidence rate was still in our country about 1.5 million, 1.4 million per year, and this 3.9 million is the prevalence rate. Again, this is the some of that article. These are some of the factors which we say: the tobacco smoking, cigarettes, cigar, alcohol, red and processed meat, obesity, and then AIDS virus, hepatitis virus, HPV virus, and sun exposure. This is more in Western population. Compared to that, what we have is smoking is not so common, but smokeless tobacco is common, which is leading to high incidence tobacco, the oral and head and neck cancer in our country. Alcohol, local made, and these all these local brands which are there. Alcohol is not that much linked with the high incidence of cancer as compared to tobacco and other factors. Like we have a very habit of taking deep fried food, and then obesity is still coming up in our country. Then in our country, when we talk of virus infection, then HPV takes the toll. That highest number is because HPV in Western population, HPV now is coming down because of vaccination, and as such, the better hygiene and cancer cervix incidence is much less, but the breast cancer is rising. In our country, cervix still about 10 years as was number one cancer in female. Now the breast has taken over, and cervix has gradually come down, and still it is fairly high. And that's why in our country, human papilloma virus, which is the main culprit for producing cervical cancer, we feel that is an important entity which should be looked after by giving HPV vaccination. And then HIV and hepatitis B infection again is common for liver cancer. And then what we also do, we do not know some other factors which are there, but still incidence rate is very low compared to rest of the developed countries. Again, I'll repeat, whether it's because of poor recording of data or it's actually low, we still yet to understand that. So these some of things which is this crude age specific crude date crude data, and you see then above 35, see how the incidence rate keeps rising. And that's a different story, that in our country the aging population number is not so much as compared to Western population. So that will be one of the factors that the overall incidence number of cancer cases are less in our country. So if you see from 0 to 4, the incidence is 11.04, 10.41, 9.25, which is the age for least number of cancer cases, 10 to 14. And then it starts gradually rising, as we say, bimodal peak. So it starts gradually rising again. And from the 35-year onwards, gradually it keeps rising. But as we know that population above 70 is still not very high, but although the incidence is very high. So when we talk of crude rate and age specific rate, the difference is there. But ASR rate, what we call the age specific rate in Western population, they are almost in the range of 300 plus. In our country, still 100 plus. So why so? Still need to be seen. And here I like to give you an alarm that when we talk of aging population, as I showed in the previous slide, cancer incidence starts rising rapidly after 35 years. And as the age goes on advancing, the incidence keeps rising because so many factors which we can always discuss upon. Now, here you see the difference. When we talk of total population in our country between 0 to 4, 5 to 15 to 9, we are focusing more on 30 to 40, 30 to 70. Now you see 30 to 70 population in is in 200 to 2011 is almost 24 million to 243 million, 24 crores. It'll rise to 26 crores in 2016, 30 crores in 2021, and 33 crores in 2026. Similarly, 40 to 45 to 59, 16 crores, 18 crores, 20 crores, 22 crores. So there is a from 16 to 22, so 24 to 33. Here we can talk of more than 70 from 4 crores to 7 crores. So almost 1.5 to 2 times that we are adding aging population in the coming years in our population. That demographic profile is gradually changing in our country right now. As in the most developed countries, the demographic profile has broad base and a narrow top. In Western population is almost the same as in fact the top is broader compared to what we have in the bottom. In our country, this is still going to change. So that means in next 10 to 15 years, we are going to add a large number of people into age group population, and which are high risk cases, high for cancer causing. And that's why you are able to see the projection which is there. Like in 2011, in males and females are almost about 0.6 million cases each. In males, 0.6, and slightly less in male and slightly more in females. That's not statistically significant, but about 1.2 million cancer cases in our country in 2011. And when you come to 2026, it's almost coming to 18.66 million, 18.6 lakhs, 1.86 million. So that means almost we are going to make it 1.5 times between 2011 to 2026. So that means we need to do something about it. And this is what I'm just trying to show a little bit how much shortfall we have in 2006 in the facilities which we have. This is the requirement ready for facilities, and shortfall in 2006 is this much. And I'll show you the subsequent slide that shortfall over the period of time in our country is going to increase because we are not adding the matching number of facilities compared to the increasing number of cases. So whatever we have today, the gap is gradually widening, which I'll show you in the subsequent slide. This is a slide which I just taken a photograph just short while ago from the computer screen. May not be very legible, but what I'm trying to impress upon this, the cancer incidence cumulative risk, this is NCRP data, although again there is a discrepancy here. They say in 2020 there are going to be 1.4 million cases, and by 2025 1.6 million approximately. But again this data has varied different values and different publication which they have. But whatever we want to highlight over here, here you see the number of people, figures which you are seeing. These are incidence per person, lifetime risk of causing cancer. So this is what top on the top is Delhi. So here in the males it's 1 in 6 lifetime risk, cumulative risk of developing cancer. In females is 1 in 7. In then we have Bangalore. Then all this you can see in some of the areas in we have where the number of figures you are seeing is much more, that my risk is that much less. Here it is almost coming 1 in 30. So that is and in cities which are more developed like Delhi or Bangalore or Bombay, they're like, this is what you are seeing. This somehow it's not come so clear, but what you can see, the number of cases, the lifetime risk of developing cancer. So 1:4, 1:4, it is 1:30. So in our country itself, we see there is a wide variation in the causation of cancer because of varying lifestyle, the rural-urban divide, and the economical factors, which make in fact, if you see the average incidence of cancer which we have in a country, it's about 100 per 100,000 combined cumulative all over the country. But the same you find in Northeast, in Mizoram, Meghalaya, these areas, it is about 250 per 100,000 compared to national average about 100. And in some of the rural areas like Barshi, it's just about 160 per 100,000. So the range is between 60 per 100,000 to 100, 250 per 100,000. This is because of lifestyle, because cancer is by and large related to lifestyle. And tobacco, here you are seeing on the tobacco related cancer almost 37. This was 3.31 million in 2020 and 0.42 million in 2025, which is projected. And gastrointestinal cancer is 0.27 million and 0.31 million. Gastrointestinal are related to the lifestyle, with food habit. And tobacco related, of course, we know what they are. And breast cancer is 0.2 million to 1.23 million. Cervix uteri is still 0.075 million to 0.085 million. So this is still on the rise. And what is important to see, the corpus uterine and ovary, they are rising. Lymphoid and hematologic malignancies, almost the incidence rate remains the same, but this is because of total magnitude which is rising. Prostate is something which is rising again, and CNS again, which is rising again. These are some of the things which we have to see in our country. And this is something which I like to show is an important slide. In India, in 2011, we were having a population 1,200 million, and new cancer cases about 1.2 million, because I said the average incidence in a country is 100 per 100,000. So a population of 1,200 million, we had 1.2 million cases. But by 2030, we expect the population to be 1,500 million, but new cancer cases 2.5 million. So you can see the population is rising just by about 25%, but the number of cancer cases are doubling, more than doubling. And if you compare to the world population in 2011 was 7,000 million. By 2030, we expect to 8,000 million. But world number of cases is 15 million in 2011, and it's going to be 20 million by 2030. That means there it is increasing just about 25%, maybe one third more. But in India, we are doubling. So that means we have to be more careful in prevention and early diagnosis, so that, because best cure is when either we prevent or we cure in the earlier stages. Late stage results are universally poor, whether USA or India. Stage 4 results are universally 10%, and stage 1 results are purely 90%. So we have to focus on things for prevention and early detection for better results on treatment. Another slide which I like to focus attention upon, then when you talk of developed countries, they have economic resources of 95%, and developing countries economic resources just 5%. But for these 95% of economic resources, then the load of cancer cases in these countries just one third, while developing countries with just 5% resources have two-thirds of cancer cases. That means we have to find out the methods where we can treat these patients at much lower cost of treatment, because our economic reserves was not that high to permit us the expensive treatment which is happening now. And best for that again is prevention, because prevention is much cheaper than what the treatment is. So because of economic reasons also, we can't afford a costly treatment for cancer. And this is what is important in our country. Like developed countries have 80%, more than 80% patients in stage 1 and 2, and less than 20% cases in stage 3 and 4. In developing countries, less than 20% in stage 1 and 2, and more than 80% in stage 3 and 4. And you see the cure rate, stage 1 and 2 cure rates are more than 80%, stage 3 and 4 cure rates are less than 20%. Here the treatment is an early stage, the treatment is simpler, maybe single modality is good enough, either surgery or radiotherapy or sometimes chemotherapy are good enough. In late stages, many times you have to combine different modalities, the treatment is more complex, expensive, more complications, results are poorer. So most important is that we shift these 3s and 4s to 1s and 2s, and 1s and 2s to C and C2 or prevention. So this is something which we need to shift upon. And here which is mentioning that number of cancer center what we have now is about 500, present need is 700, the shortfall is minus 200. We are adding about 15 to 20 cancer centers per year to a country, and if we continue the same rate, then by 2030 we need 1250 centers. But if we continue at the rate of 15-20 every year in the next 10 years, that means 10 years we'll be able to add another 200 centers. So 500 plus 200, 700. The shortfall will be 550 centers. Now at the moment the shortfall is 200 centers in the country. But by 2030, when our need will be more, the pace at which we are increasing, that gap is going to be widening. So you see that everywhere, what is the column is the present shortfall, and this column is the shortfall by 2030 by the number of cancer cases we are going to expect. So you see minus 600 is going to minus 2000, minus 350 is going to minus 1200, minus 400, minus 1200. You see this, that was for the equipment part. But if you see the manpower part, so minus 1000 to minus 3200, minus 1300 to minus 3500. So this gap in our country is increasing. That means we have to act on multiple levels. First of all, to try to reduce the number of cancer cases, try to prevent the cancer incidence, try to diagnose them in early stages, and by doing also, still we'll be able to pick up a patient in earlier stages. And when we pick up patient in earlier stages, it becomes a bounden duty to be able to cure them, because the early stage patients are those which can be cured. And if we do not have enough facilities, then all these early stage cases will allow them to progress to late stages, where the result will be poorer. So that means we have to act on early prevention, early diagnosis, and at the same time augmenting our treatment facilities, so that whatever we are diagnosing early, we are able to treat them. Otherwise, even if we diagnose early, we don't have the facilities to treat them, what is going to happen? We are going to make them psychological problem as well. So these are some of the factors. In the UNO in 2011, a meeting was held to which India was signatory, and 2020 was the target to have all these facilities for cancer prevention and treatment in all the countries uniformly, and India was a signatory to that. But what happened is, so far, what happened for health for all by 2080? Do you remember that there was a very strong move in 1980s that health for all by 2080 in India? So that is 20 years back. So we are still the same. The slogans are there. So here again, we had the targets which were fixed for by 2020 as per UNO, WHO, UICC. India was a signatory to that. So there are some 11-point charter, but unfortunately nothing has happened. So I'm glad that you youngsters are coming forward and making yourself aware at this stage in your life, because unfortunately in the medical curriculum so far, cancer has never been given that much importance which should have. Because we are always focused upon infectious diseases. But now is a high time that in our country, not only that we have to deal with infectious diseases, but we also have to deal with lifestyle diseases, which includes diabetes, heart attack, cancer, and all these road accidents. Then late neurological problem, Alzheimer's and dementia, and these, because these things also will start coming up, have already started coming up. As I showed, the aging population increasing, lifestyles are changing, the population, the pollution is increasing. So all these factors will lead to the lifestyle related diseases. And so in our country, not only that we have to take care of the infection part, we also have to take care of the lifestyle related disease part. So there's one country which always say that you have to, you see on the road bullock carts also, and you see on the road Rolls Royce also. You have rockets also going to the skies. You are reaching the moon, but still you have people who are still dying of starvation, and still dying of cold wave and heat wave and all this kind of stuff. So we have to act parallel on so many prongs together. And this, I'm very glad to see that youngsters are taking the lead. You have off your own, you have started. We didn't ask you to do it, and you started off your, and we are happy to see that. So that's, I want to sensitize you towards this future need which is coming up in our country. So these are some of the factors which are showing you, and these are age incidence rate in our country. This is there, and this is of Delhi data: lung, tongue, and larynx, or urinary bladder and mouth, which is a tobacco related cancer. In males, the incidence is gradually rising, despite the fact that the reporting may not be proper. Still in females, this tubercular cervix had been associated with the cervical cancer in some of the studies. So but this top line is cervical cancer, which is gradually declining, but other cancer are still, either in females we don't expect that much of tobacco chewing habit which is there in males, so their incidence is maybe the same or slightly increasing. So this is for Delhi data. This is all sites, all sites in males in Delhi, Chennai, Mumbai, Bhopal, and Bengaluru, and Barshi. Barshi is a rural-based population based registry, and these are all the urban population. So you can see there is a very major difference between the incidence rate in the urban population and the rural population. But what the crux of the story is that for urban population, we have incidence rate which is about more than 120 per 100,000 in Delhi, and then Chennai, and almost in Barshi it is less than 60. So this is for few 6 sites which you have, but here it is still missing, because we have started registry in northeast population, and Mizoram, the incidence is highest in the country. Mizoram and Meghalaya and all these northeast state, these are 250 per 100,000 because of tobacco smoking habits over there. This is for again joint point regression model for males. This is for females. Again, you see the incidence is gradually rising, and what marked difference is there in Barshi, which is a rural population, incidence is low. Now whether that is actually low or is under reporting, patient are not coming for diagnosis and dying, and we do not know what they're dying, how they are dying, but whatever data is there, I'm showing you that. So we have to be, this is joint point regression for that. And this is something which is interesting, I'll show you. We don't have this kind of very important data available from our country, but this is the USA data from 2016. And you see USA has 1.6 million total cancer cases in their country, almost same number as we have in India right now, but their population is 1/4 than what we have. So that means the incidence is almost 4 times than what we have in our country. And you will see over here this is for the male, this is the female, this is the incidence pie diagram, and this is for female incidence pie diagram. And you'll say lung cancer incidence rate is about 15% all cancer. This is more of relative distribution of different important cancers in males. 15% in is lung cancer, and 25% prostate cancer, which is very high in those population. In our country, still rising. But you, on the other hand, you see this is the mortality chart. Lung cancer, the incidence rate is 15% of relative proportion. But when you talk of mortality, in mortality is that 31% of all cancer cases are dying of lung cancer. So that means what we are diagnosing, we are not able to save them much. On the other hand, you see how the prostate cancer, although the incidence proportion is 25%, but in mortality, their control is only 10%. That means prostate is more of indolent kind of a cancer. So here you can see the difference between many of those cancers which we are diagnosing, but their mortality proportion is less. That means we are able to fight them better as far as the cure is concerned. Similarly, on the female side, you see the breast cancer proportion is almost 26% of all cases, but mortality because of breast cancer is just 15%. That means we are able to manage them more effectively compared to the cancer. So you can see that colorectal 10%. That means where you see the proportion and incidence is high, and proportion in mortality is low, that we are having better cure rate for those cancer. But on the other hand, you will find some of the cancer, like you see the pancreatic cancer over here, 3% is the proportion in the incidence, but in mortality is, I think is, yes, is 6% over here. Like I showed you for lung, is in incidence the contribution 15%, but in mortality the contribution is 31%. And lung cancer is one which is directly related to tobacco smoking. In our country, we are still not seeing that high lung cancer cases, because the people are dying more of smokeless tobacco chewing habits. But both are bad. Tobacco in any form is bad, and at least I'll request you that as this age, you should make it as a motto in your life, that whomsoever you're seeing in your friend circle, in relation, in your patient or the patient attendants, whenever they are coming to you, if they are smoking, give them a counseling so that they should stop smoking. So this is something I just wanted to show you in nutshell. Then there's so many things we can discuss, but these are the background I wanted to give you for the youngsters to see what problem we have in a country, and why the cancer incidence mortality is almost same in a country, and what we should do about it. So this is a brief introduction which I had given you. So let's see now what others have to say and what the students have to ask. Thank you. Thank you for listening.
Thank you so much, sir. I think this has given us a very, very clear a very clear overview of the incidence of cancers. And it was a really enlightening way in which you had told everyone through the diagrams. I think everyone has got a really very clear view. So I would move to Zainab.
Also correctly mentioned that sedentary lifestyle, physical inactivity, increased consumption of fatty foods, etc., are major risk factors for cancer development, and not only culprits for obesity, cardiovascular diseases, and diabetes mellitus. So I present this question to Dr. Acharya, sir. Sir, please throw some light on these lifestyle changes and their effects on cancers.
Yeah, I think Dr. Grover made a very good presentation on the complete epidemiology of the cancer throughout the world and India, of different cities. And if you see the last slide, what he showed, the recent slide he has taken today from the ICMR, if you see the first incidence, it is the GI cancer, because 2020 it changed from breast, cervix, and head and neck. GI became one of the most topmost causes for the cancer. I think Dr. Grover can also share that slide. The number one cause is the GI cancer. It is only because of our food habits. If you see the today's food habits, all the school children, everywhere you will see everybody is going for the junk food, what is called as the pizza, burger are being taken by everybody. And if you see the so-called modern people, they are after kebabs. If you see every street, every house will be having kebab being made. What is kebab? Kebab is nothing but burnt meat. If you see, whether it is chicken or it is mutton, whatever is being taken, it is in pre-carbon state. Before it is being completely made into carbon, because if you have seen in your house, a few sugar cubes are being roasted on a tawa, you can see the pre-carbon stage, and if you taste it, it will be very tasty. But the problem is that it is pre-carcinogenic, and that is why it has been told that whatever kebabs we are eating, whether it is vegetarian, paneer tikka, or whatever, I'm not naming them, but because they have a lot of spices, and along with that, they are in the pre-carbon stage. So I have been running a campaign of making people aware that you can have chicken curry or mutton curry, but don't go after these kebabs, because this pre-carbon state, which is causing you the cancer. Because as sir told, that Northeast is also having the highest incidence of cancer, and most common being stomach cancer and colon cancer, because whole of the Northeast preserves the meat not in the fridge. It preserves the meat over the hanging from the roof over the chula. The chula is from wood chula, लकड़ी का चूल्हा होता है और उसके ऊपर smoke होता है. The smoke burns the meat, and that is how it is being preserved for months together without being without being decomposed. So all these pre-carbon state, if I see Sikkim, if I see Nagaland, if I see Mizoram, they are the highest number of stomach cancers. I have treated their health secretary's wife. I have treated the DSP. Everybody is having GI cancers. So it has been seen that diet plays a major role in today's cause of GI cancer. And similarly, number 2 is obesity. Obesity will definitely lead to more incidence of breast cancer, cancer of the endometrium, ovarian cancer. Then you have the other forms of causative factors like tobacco and alcohol, as sir told, lung, head and neck, tongue, all these. So there is a lot of factors are related to our diet, lifestyle, and physical activity. Because you see, we are doing the most least physical activity at present, and in the corona times especially, we are not moving out, we are inside the house. So it is very important that if you don't do activities, then what will happen? Ultimately, the energy, you eat more and spend less energy. So that is why, especially for me, I had done whole of the corona times, active corona times for 6 months, one day meal, when I was not doing much activity. Because if you take more and spend less energy, definitely it will lead to obesity. And that is why my point is that there are factors, let us say genetical factor, hereditary factor, environmental factors, which you cannot change, because they are not changeable by your own self. But you ask yourself, diet, lifestyle, and whatever you intake, this is the thing which you can change. It is with you. If you want to become a vegetarian, nobody is denying. In a month, once or twice you can take non-vegetarian, that too only boiled or curry food, not the very spicy food or the kebabs or pre-carbon stage. Similarly, if you see the alcohol and tobacco, very well, as sir told, alcohol is not that much associated, but tobacco has definitely shown, whether it is chewing tobacco, smoking tobacco, has definitely have association with tongue cancer, oral cancer, and lung cancer. So I think they can be changed. And third is the lifestyle, is that the 4 major cities like Delhi, Bangalore, Calcutta, Hyderabad, they have higher incidence of breast cancer, because the females are working females. They have the stress from the house, they have stress from the job, and they are always on the run. So they have what is called as stressful life. So the lifestyle has to be changed by doing meditation, some kind of physical exercise, so that you are stress free. Because females are the backbone of the house. If one female at the age of 36 or 40 suffers a breast cancer, the whole family suffers. So the same way, if a 35 or 40 years male suffers from an oral cancer, he is at the maximum earning to the family. So both ways, it completely abandons the family because the family started with a treatment. And unfortunately in India, 70% of the cancers are diagnosed in advanced stages. So what is called as rule of 70 and 30, 30% are only coming in early stages. Dr. Grover will agree with me. He can put some points that we want to reverse this ratio. We want to diagnose our cancers early in 70% of cases, and that will happen by creating awareness, by doing prevention strategies. And that is why I again congratulate you for doing such activity, so that it is not only these 450 participants will benefit, they will pass on this message as a cancer awareness to the rest of the society, and that will incite some form of prevention and lifestyle changes, so that we can prevent cancer. And if we at all detect, we will detect it early. If time permits, I will share one or two slides. But first, I think let us take opinion from Dr. Grover on or Dr. Binita on the 70-30 ratio of cancer detection.
No, the 730 you said is okay, because what I showed the slide, it what we normally says 2080, because you are working more a private sector. So there you get patients which are relatively more enlightened, and they tend to come early. They are more conscious health point of view. When we talk of in government sectors and take a general view of the India, in most of developing countries, including India, then usually this ratio is 2080, which I showed in the slide also, that we shift this 80s and of 3s and 4 to 20s of 1 and 2. And 20s of 1 and 2 to pre-cancerous stage or cancer prevention. So 30, 70, 2080 is not so, I'll not say there's not much difference, but what is important to understand that majority of patient development countries, they report in late stages, which we have to move towards the early stage part, because treatment in late stages is difficult, more expensive, and less rewarding. Results are poorer. But in early stages, the treatment is simpler and results are better. It's cheaper, results are better, the complications are much less. So that advantage is also there. And that is the best thing. And you have almost in earlier stages, you have average 80% control rate. In lower stages, you have average 20% control rate. So this is something which we have to understand. And then the ladies, again, what you are talking, yes, that's fine, right? They're all working ladies. What is equally important along with that is that marriage at late age, because they are all getting education, higher education, getting career oriented. So the average age at marriage now is around 25 years for a female. And although that prevents from cervical cancer, but predisposes the risk for breast cancer. So we have to strike a balance. The best age at which we have the least number of cervical and breast cancer cases is 21, 22 years. And first child should be around 22, 23 years. But with the present age life, which is everybody is career oriented, whether boys or girls, usually this is not happening. But still, breast is something which we can diagnose much earlier. And with even with conservative treatment with breast cancer and surgery, we can give very good result, which in cervical cancer results are not so good compared to breast cancer. But what is important is that through awareness, we make them enlightened to come early and get them self-examined for early detection, so that we can pick up a disease which is less than 1 centimeter in size. And it's quite possible with these days technology is available. So awareness for any cancer for early diagnosis must. And for those cancers which are preventable, we should be able to prevent. And fortunately, in our country, we have almost more than 50% of cancers which are preventable. Like I said, almost 30% cancers because of tobacco, which can be prevented. Cervical cancer, almost 10%, which can be prevented. Then even life related, which was mentioning, the diet is one of the factor which is associated with the large number of GI cancer. Although in our country most of are vegetarian, but amongst them also still we are not taking a balanced diet. And what Dr. Acharya was mentioning, right, it's the hydrocarbon, the food, the smoked food, which is something which should be avoided always. Like even the smoke which is coming from chulas, that somehow is now being brought down. But as we had the example, like in you say in northeast, similar in Kashmir also, they have a high incidence of esophageal cancer. because the habit of taking very hot tea, which is kahwa, and then spicy food, non-veg and all. And again, some how our lifestyle is related with the causation of cancer. One unique example again is Kashmiri's Kangdi cancer. They keep that heated furnace just in front of their stomach, in the on the abdomen, and you see that that skin cancer, which is typically called as Kangdi cancer, because they're keeping the Kangdi over there. So just only to
Yes, yes.
make you to impress upon this point, that most of cancer in all of the world, they are related to the lifestyle or habits, and whether it's tobacco chewing or food, or like Kangdi cancer. So these are lifestyle factors which are associated with large number of cancers, which are preventable. Of course, something which is associated with your ultraviolet rays, or even that also, like in Western population with ultraviolet rays, they go and take sun bath because the skin cancer is high. If they can prevent that, maybe the skin cancer will become low. But skin cancer is so easily curable that we do not even count skin cancer in the incidence. So whatever incidence I show you, that does not include incidence of skin cancer except melanoma. Melanoma is included, but normal skin cancer, basal cell carcinoma, squamous cell carcinoma, these are not included in overall incidence. Otherwise, the incidence will become almost double of that. But still, it also shows that if a white skin, if they expose themselves to sun, the high incidence of getting skin cancer. So what we are just all of us trying to make the same point, that many of the cancer are preventable through a lifestyle, or activity in life, or food habits, or that kind of thing, which are which are within our own hands to control. Then whatever is not controllable, that's a different story, because after all, we are not immortal. We all have to die for one or the other reason. But something which is coming at the age of 70, 80, 90 is that is expected, because by that time your family is settled, everything is settled down. Now it's time for you to go gracefully, it's fine. But because of our habits, we are preponing the incidence of cancer to 30s and 40s and 50s, when whether it's male or female, they are all pivot for their family. So this is something, through your awareness we can bring it in the population, that change your lifestyle in that manner, that we do not prepone or invite cancer at an age when it should not have happened. So this is something which I'm glad that you are coming forward with, and the message should go down across the society to everybody through you. Of course, you'll all be the future. Many of you will be future oncologists. Many of you will be future endocrinologists, heart specialists, or neurologists, whatever. But everybody we should be aware of the strength and weakness of each other. At least we all should be able to pick up a cancer at an early stage, because unfortunately a patient is coming to us, by the time is already is delayed by about 5-6 months, because the family physician or maybe some of the indigenous practitioners who were not able to diagnose it, so they delayed the whole process of picking up the patient at early stage. So many of us will be family physicians also. So it's important for all of us to understand what cancer is there in early stage, what's the time for us to intervene. Not all ulcers will be cancer, not all tumors, nodules will be cancer, but that suspicion factor should come in the mind. Is it so? Should I exclude it? Should I investigate it? If I'm not able to do it, let me take a opinion of the specialist. So this awareness must be there in everybody, in all the doctors of any pathy or any medical discipline. This knowledge should be there in everybody, that cancer is preventable, in early stage it's curable, and we have method to pick up the cases in majority of cases, where we can pick this disease in early stages. Well, there are limitations somewhere, like ovarian cancer, still it's a challenge. So the esophageal cancer still is a challenge, but lung cancer, but lung cancer is preventable. Ovarian cancer may not be that easily preventable. So this is some of the points which always should be thrusted on everybody in our community. So let's proceed with Dr.
Sir,
Acharya.
just Ritika,
Yes, sir.
this is I will share only three slides.
Sure, sir. Please.
You see, this is a early cancer. The lady has been diagnosed after a screening mammogram. So if you diagnose a lump in the screening mammogram, it is very small. We cannot see in the proper mammogram. So we did a J needle localization. J needle is a wire which goes into the tumor and it gets localized, and then the excision done. And finally, if you see the outcome, it is the carcinoma in situ, which is called a stage 0. Now, if you see, this is what is called a J wire. The J wire is put in the lump, and the specimen is taken out with the wire, and again the mammogram is done from the specimen, and we shows the lump. So this is where the carcinoma in situ. Now see the difference. Now another, let us say lady B, it comes with a lump detected by herself, and then she comes to the surgeon. The surgeon does a mammogram and then a FNAC and a ultrasound, and then from the FNAC or the true cut biopsy, we diagnose the cancer, and she undergoes what sir told is breast conservative surgery, because nowadays we are not going for mastectomy, we are going for breast conservative surgery and some form of simple chemotherapy, or if it is a post-menopausal, she undergoes only hormonal therapy. So, and if you see, this is stage 1 and the cure is 90%. Now, if you see another lady, who is a lady C, he noticed a lump similar to her the other person like lady B, but she neglected for 1 year. And what happened? From peanut size, it has gone to a lemon size, from lemon size to a orange size. So, which is quite big. And now this will be called as locally advanced breast cancer, where the skin will be like orange peel or pudgy orange. So it will be a stage 3 or stage 3B cancer, because the skin will be having pudgy orange. So here, if you see, the person has to undergo mastectomy definitely after a intensive chemotherapy, because we don't operate locally or advanced breast cancers directly. So the person has to go for chemotherapy, then she will go for mastectomy, and after that radiation, then she further takes some chemotherapy and hormone therapy, and chance of cure is decreased from 90% to 40%. So that is why we say early detection is the key to cure. Okay, so it will be very difficult if you see the cure travels from 100% to 40%. So this is very important that if the diagnosis is done early, then only I think the cure can be guaranteed. Thank you very much.
Thank you so much, sir. I think both of you have enlightened us so much, and especially on the lifestyle changes. Honestly saying, I was not aware that why you were telling you why you were emphasizing more on kebabs, that we should not have it, and why we can have curries and all. But now I think most of us know the reason. These are small confusions which we have in our mind, and which many of them have been cleared. So now I think we finish our first segment, and let's move to the next segment, that is cancer screening and prevention. So as Sir correctly said, that early diagnosis and early detection is a way of preventing cancers. So I would like to ask Sir, Acharya Sir only, Sir, if you could please enumerate some more preventable cancers which exist.
I think preventable breast is preventable, head and neck, and then lung cancer, as Dr. Grover told, then GI by becoming a complete vegetarian diet, and similarly for cervical cancer, I think Binita can put more points, because it is said that one pap smear can give you a cure completely free of cancer for more than 5 years in a lady. So, but in India, to tell people that to do a pap smear is next to impossible. People are not coming up to do a pap smear. And like Binita can highlight on the gynecological cancers much better.
Thank you so much, Sir. Actually, Vinita ma'am, due to a very urgent family emergency, had to leave us, and she is not able to join us. So I think we have to, we'll be with both of you, sir. I think both of you are really enlightening. And I would request now Zainab to please ask the next question. Zainab?
Not audible.
Uh,
Okay, am I audible now?
Yes.
yes, yes.
Yeah, I was saying that I completely understand there are still so many hurdles which need to be overcome before we can make everybody
Voice is
aware
very low.
about cancer. So,
Very
can
low.
you hear me now?
Yes. Who's speaking? Zainab?
Yes, sir.
Now it's audible.
So I was saying that I completely understand that there are so many inhibitions that people still have when it comes to early diagnosis of so many cancers. So I would like to present this question to Dr. Grover, sir, about the early signs and symptoms and risk factors of some preventable cancers. Like, how do people get to know that if certain signs and symptoms are occurring, so they can at least get a hint that they need to get themselves tested now?
Actually, let me tell you, there's nothing which is very specific as early sign of cancer, because same symptoms can be there because of all non-cancer disease also. And we have a habit of neglecting our health at least till such time it becomes an emergency. Unfortunately, Dr. Nita has joined, she's back now. So we have a habit of developing neglecting our health till it becomes an emergency. We all are very alert when we have to get a car serviced. We'll keep checking over now 5,000 kilometers crossed, 10,000 kilometers crossed, but for our body we are not concerned at all. So what we normally say, after 40 one should get an annual health checkup. Screening is an annual screening method which not only just diagnose screen for the cancer, but also screen you for diabetes, for any cardiac problem, any hypertension, or any other associated lifestyle related problem. So check you for that also. But to say so, when we talk of common symptoms, when you always say if there is any lump or nodule anywhere in the body, especially it is painless. Let me, everywhere when the cancer starts, as even as early warning signal, the initial symptoms are without pain, except in bone cancer and brain cancer, where the first symptoms start with will be pain, and swelling will appear later. But in most other sites, if the lump is coming, like in breast cancer, nodule initially will be painless, and it's a painless lump which lady tends to neglect. Nothing, my child has hit his head against my breast, or maybe something has happened and some blood clot has come. So they don't pay attention to it till it becomes painful. And generally when a cancer nodule becomes painful, it's usually late because it's already infiltrated into the nerve roots. So this is something which will impress upon, that a lump or nodule anywhere, especially if it is painless. Bleeding, abnormal bleeding from anywhere, again if it is painless, because if something which is associated with pain, the patient will run to the doctor much faster. But painless, they'll tend to neglect. And cancer, generally they need bleeding to start with. Abnormal bleeding from anywhere, it will usually be painless. Pain will come later. So then any difficulty in swallowing, you change in your bowel or bladder habits. If you are normally what we call as altered bowel and bladder habits, all altered bowel habits, then abnormal maturation habit, there are some, then headache which is persisting, or blurring of vision is persisting. So there's some of the things which we have to focus upon. We have to impress upon the public that if these symptoms are there, come and get checked up. But what happens when we say come and get checked up, there might be cancer, people tend to avoid that. Once you go to the doctor, they'll diagnose cancer, why should I go? So that evasive attitude is there. We have to make the people enlighten in this manner, that don't come for cancer checkup, come for a regular annual screening. Like, unfortunately good that in government sector, for all their officers, it's become mandatory for them to have an annual screening before, and that gets entered into the annual confidential report, that they got themselves screened and they got the basic blood test done. But what this should happen for everybody. But unfortunate part is that in our country we do not have adequate health facilities for even disease, those who are ill. And when here we are talking a person who is not ill and he should come to the hospital and get himself screened, so they'll see the crowd and run away from there. So we have to develop a separate, like these days when we're talking of well-being clinic being coming up, so there we talk of that people should be going over there. Because unfortunately in our country everything gets blown up disproportionately. Now many of the private labs, they are coming up, okay, come yourself, get checked up, 1,000 rupees, get 64 tests done, get 65 tests done. That is not a screening. It has it blood test cannot replace a clinical examination. And many of the history which the doctors take, and which from that history, many times they try to evaluate that what kind of risk this patient is likely to have, and not only just cancer, heart problem or diabetic problems, or many factors are there with many lifestyle related diseases can be picked up. So consultation with the doctor is a must, and then doctor should advise what kind of blood tests or any other investigation which you need to undergo for suspecting something if you have. But here patients generally what they say, if you go to the doctor, they'll diagnose something, and let's better not to go, let's avoid, least realizing that if you're delaying the disease and set is not going to just stay on like that, it will keep progressing. On the other hand, we also have situation where patient go to the doctor and they unnecessarily over diagnose, over treat. So many things are there. So best is the patient should have a family doctor, trust upon that, and family doctor should be made aware of all these lifestyle related diseases, not just cancer but other diseases also. There are certain common symptoms, common which we say cardinal signs for cancer. When you go to American Cancer Society, their first alphabet, everything says caution, change in bowel or bladder habit, and then altered bowel. But change in bowel bladder is the first symptom. But in our country, change in bowel bladder is not the commonest thing. So I have changed. I reframed it accordingly. In our country, breast cancer, cervical cancer, they and females, they are almost constituting about 30-35% of all cancer cases. Because normal human psychology is that you remember just top one or two or the last one or two. So our focus should be change any lump or nodule anywhere in the body, especially it's painless. Any abnormal bleeding from anywhere, especially if it is painless. Because many times you have in kidney stone, when the bleeding is there, but it's associated with pain, patient will rush to the doctor and get diagnosed with stone. But if it's a kidney cancer, the bleeding will be there, it will be painless. Bladder cancer, bleeding will be there, it will be painless. So patient will not go to the doctor. So nothing, I might have eaten something with some garam खा लिया होगा, कुछ ऐसा कर लिया होगा, उससे हो गई होगी, पानी पी लेता हूँ, कुछ नहीं होगा. And even single episode is important because that was the initial warning sign you had. Maybe second bleeding because of cancer might come after 3 months. But during these 3 months, the cancer was not sitting silent. It was gradually increasing. So this is something which you have to make the people understand, that this for your own body, you also get yourself service at least once a year, just for a day, where you get yourself checked up for all these things. Despite the warning signals which you have, these warning signals is good that the physicians, young family physician and doctors, they should be made aware of, because patient honestly they get panicky. On the other hand, they'll see alarm, they'll rush to doctor, mere ko cancer ho gaya. So you have all the extremes in the society. But it's as a doctor, we have to keep a balance and evaluate that what kind of risk this person has, because of age or lifestyle. Because cancer, again, with age, the incidence of different cancer keeps increasing. As I said, there is a bimodal peak. There is initially in the early childhood, then there's a healthier period in between, then gradually start rising again after about 20 to 25 years, and then keeps rising till the end of the age. So we have to see at what age, what kind of cancer is more common, and what is the occupational history of the patient, what is the personal lifestyle history of the patient. Depending on that, what kind of risk factor the patient has, what kind of obstetric history the patient has, the Dr. Vinita will be able to highlight better, as Dr. Rudra was telling. But cervical cancer is something which is really preventable, and not only through cervical screening with patient, but these days the HPV vaccination is now available in our country also. HPV vaccine is something which in a Western population, the incidence has seen to be going down, at least in carcinoma in situ, which the initial phase, like incidence has come down. Because in cervical cancer, vaccination which we are giving is at around 13-14 years of age, and cervical cancer incidence comes around 40 years of age, that means after 25 years. So we still do not have that follow-up for 25 years, because cervical cancer has come in the field for about 20 years. But whatever pre-cancerous cases which were there in the previous period, those incidents come down. And maybe Dr. Vinita will be able to highlight better on all those gynecological cancer which Dr. Rudra had just left her for that. So she has joined back, and let's hear to her what she has to say about it.
Absolutely, sir. I think we are very happy, ma'am. Thank you so much for joining us back. And without wasting any more time, we would request that you please emphasize on the gynecological preventable aspects of the cancers.
Your voice is muted. Dr. Mehta, your voice is muted.
Ma'am, you're muted?
Am I audible now?
Yes, now.
Yes.
Okay, so Ritika, of all the gynecological malignancies, it is the cancer of the cervix, which is accessible to the eyes, and it is the most preventable one. Okay. Yes, and it is very common in our country, and every female should have proper knowledge and awareness what are the high risk factors and how cervical cancer can spread, And because it has a long latent period during which pre-invasive and pre-cancerous lesions are detected and treatable. So that is how cervical cancer can be very nicely prevented, almost 100%. And rest ovarian cancer is not preventable. It will, if it will happen, it will happen. Uterine malignancy, again, otherwise not early detectable. Vulva, yes, because again, it is accessible to the eyes. A person can be aware of the long drawn symptoms and approach earlier. As far as ovary and uterus cancers are there are certain high risk factors involved other than genetic, which if you take care, you might be able to prevent them. And if you are in a high risk zone, then if you come for regular screening, annual screenings, it can be detected earlier in earlier stages, just that much. And cervical cancer, all of us know how to be very aware of our cervical hygiene. So that's very important.
Thank you so much, ma'am. Ma'am, I would like to ask one thing, that as cervical cancer is being emphasized so much, so could you please enlighten us something on the screening of cervical cancer and also on the vaccine, because we have studied that there are vaccine preventable cancers and cervical is one of them. So ma'am, if you could please emphasize on that.
Okay, so is there a presentation coming up? Somebody is presenting something.
Yes, I think
Already
Dr.
done.
Acharya sir is presenting something on it.
Just I was giving the slide to Dr. Binita.
Okay, okay. No, Dr. Rudra, you can take the slide. Please do that, and then I'll take you. Please.
Please, sir.
No. Just for you, I was presenting, putting these slides to tell the details.
Okay, yes. So one thing all the students must know, that pre-invasive lesion of the cancer, cervical cancer, will have no symptoms at all. Okay.
Yes, ma'am.
So screening means that ideally you detect the disease in the healthy phase. You think you are healthy, you have nothing, but you go to the doctor that just to confirm that actually you have nothing. So that is screening. And once cervical cancer steps in, then all these symptoms are for the cervical cancer, postcoital bleeding. I think you all are doctors, isn't it? Or would be doctors?
Ma'am, mostly we are would-be doctors, UG students and interns.
Okay. So bleeding during sex is known as postcoital bleeding. So all these and or dirty discharge and pain is a late symptom, like Professor Grover highlighted for breast. It's true for all cancers. Then unpleasant discharge, discomfort, pain, all these correct. So now as far as symptoms and cervix, 10 to 15 years it takes. You will be in the cancerous stage for a long time, wherein you must come to the doctor for detection. And that is asymptomatic. There won't be any symptoms. So ideally, once you are sexually active, maybe beyond 25 years, and that is when we start pap smear. Pap smear, you will be surprised to know that pap smear was the one test which came, and it was a paradigm shift because it could detect and cervical cancer early and treat it. But now it is full of fallacies because very low sensitivity specificity. So human papilloma virus, high risk viruses that we acquire and which are now known to be cause of cervical cancer, can be detected, and they're not very expensive also, through PCR tests. And so that is the form of screening now. Anybody who is sexually active, say after 25 or 30 years, every 3 to 5 years, you can do your screening with human papilloma virus testing, high risk oncogenic virus. Okay. Am I clear now?
Yes, ma'am. It's
Okay.
quite clear right now.
Virus testing, and that to beginning after 25 to 30 years. And with virus, with oncovirus, you can do every 3 to 5 years testing. But if you're doing pap smear, suppose there's no facility for HPV, then your screening has to be more frequent, maybe 1 year or 2 year. That's it. So that if you're for you to be absolutely safe. What was your other question, Ritika?
Ma'am, if you could tell something about the cervical cancer vaccine.
Okay, so HPV vaccine, there are 2 vaccines in the market and many more in the pipeline. The 2 in the market are Cervarix is one, and the other one is Gardasil. So Gardasil is for 4 kind of viruses, including warts, which are much more benign viruses, 6 and 11, and 16, 18 are the high risk oncovirus. The other one is Cervarix. Both have almost equal efficacy for cancer cervix, and this is the primary mode of prevention. And it is given in the form of 2 doses. One will be 0 dose, the other one will be a dose 6 months apart. And largely the age group should be 9 to 10 years on this side and 13, 14 years on that side, because this is the age group when the girl is able to understand things. Moreover, her immune system is the one which will take maximum development during this age. But largely some will be given from 11 to 26, or even married women are taking, though that's certainly not advisable. Sometimes we do extend for a more advanced age, say 16, 18 till 26, as long as she has not had sexual contact, and then 3 doses have to be given. But efficacy in those ages may not be that much, because immune responses development can be a bit jeopardized as the age goes. So that's it. So vaccines are being given free of cost in our Delhi State Cancer Institute. It was started by Professor Grover himself. So that's it about the vaccine. And there are some vaccine, monovalent, HPV, many strains are there, 100 plus strains. They say it keeps changing, but by and large, vaccine is very good. And it is currently being given only to females and ladies. But in many countries like Australia, even boys are taking it. So, and HPV can even cause oral cancers. So human papilloma virus, hygiene is very important. And HPV is one which cannot be prevented by HPV virus transmission. No, even barrier method of contraception like use of condoms and all also won't prevent this virus from going. So that's it. Personal hygiene and taking, you must take, all girls at the age of 11, 10, 13, 14, 15 must take this vaccine. And even if you're not married, still you can go and take this vaccine in the form of 3 doses till 26, 27 years of age, no issues. So that's your primary prevention. Then comes secondary prevention. Secondary prevention is regular going to the doctor and getting yourself checked up for the cervical cancer with pap smear and HPV testing, and be aware of the symptoms. And something called opportunistic screening, you all must know, like whenever a lady comes to us for any reason, maybe she's going for delivery case or she's going for general gynec checkup, all gynecologists must know that that is the time for doing an opportunistic screening, because cervical cancer hits hard during the reproductive years and at the prime of the life, must be detected early, treated early, so that you give good life to the ladies. And if treated well in the proper center, in proper way, it's past history. Okay, so it's not that once cervical cancer, your number of days are limited. This holds true for early stages, like it is a punchline for all the cancers, rule of thumb. Early diagnosis, early stage, good life.
Yes, ma'am. I think that makes the thing very clear. And one last thing which I wanted to ask, ma'am, that how long does the immunity last for this vaccine? Is it lifelong, or do we have to get repeated doses?
No need of booster doses as such. It is lifelong, because it's not only primary prevention, it is secondary also. You keep coming for testing. So there are no booster doses as such. And immunity levels for 5 to 10 years, they have already done antibody testing in the blood. And it is proven that there is a surge of antibodies. Beyond that, I don't think they have done this testing. But yes, it's taken that it's lifelong.
Okay, ma'am. I think that's very clear.
2 doses only, or 3 doses for girls beyond 13 years.
Okay, ma'am. That's very clear, ma'am. Thank you so much.
It is very important that the age of vaccination is 13 to 26 years. That is pre-marriage and before having any kind of sexual exposure. So this is the only thing where the virus can be prevented, because the more late you put the vaccine, the chances of getting the prevention is not good. So I think it has not been included in the standard universal immunization program of the country, but still it is almost now available at most of the immunization centers. The person has to pay, which is very less, I think. 2 kinds of vaccines are coming, and everywhere it is available. So now we are always telling our patients to give to their daughters, to like we should make a point for also vaccination of all the students even.
So
Yes, sir.
ideal age is less than 14. After 14 till 26 is always recommended for 3 doses, but the best is less than 14. And because
Correct.
you also expect that by that time, even if somebody is not married but might have had some sexual exposure or some other reasons which could be there from public toilets and all. So ideally, as per WHO, the recommendation is less than 14, between 9 to 14, 2 doses. And after 14, if the girl is not has a sexual exposure otherwise, then 3 doses could be given. But once a girl is married or sexual because this is a vaccine which can prevent HPV infection before it has actually occurred. Once HPV infection
Yeah.
has occurred, then it cannot prevent. So after an HPV exposure, then there's no point in giving this vaccination. And similarly for Pap smear, although it's the most ideally recommended modality since ages, but in our country, the logistic is you do not have so many technicians, so many pathologists to report a Pap smear, because you see the number of ladies which are there in that. Even if they talk of somebody between 35 to 45 years of age group of ladies, even in once in lifetime, this ICMS study, then even once in lifetime study has been done, is Pap smear is done, the incidence can be brought down to by almost 1/3. But even for that, for 10 crores ladies, if you have to do a Pap smear, how many technicians, how many pathologists, how many gynecologists you need? So these days, even we have HPV antibody testing done also, which is simpler, is not so embarrassing for the lady, in which you don't need a cytotechnicians and you don't need a cytopathologist, more from a by machine it can be done, but those facilities are not there. So till as long as we do not say that Pap smear should not be done, we have a limitation. Within those limitations, we should be able to extend the facility as long as possible. But at the same time, we should impress more upon young girls getting vaccinated with HPV vaccination. As Dr. Nita was mentioning, as far as the current knowledge, we do not know how long the immunity is going to last, but for till 20 years, we have seen the plateau of the antibody is there. And we presume that if it is lasting, that's it almost 20 years, then it should last for lifelong. So as per the current knowledge, the booster dose is not recommended. Because as I mentioned earlier, once we are given the vaccination in countries like Australia, USA, Canada, UK, where it started about 10 to 15 years, 20 years before. So there the incidence of carcinoma in situ or CAN has been seen that has come down. So that means it's effective till even 15, 20 years also, because for cervical cancer to develop, initially it goes through phases of CIN and then CNC2 and then to invasive carcinoma, which takes about 10 to 15 years. So that incidence of CIN, which should have started by about 30 years in those girls that vaccinated in 13, 14 years, that incidence has certainly been brought down. And as the boys were concerned, and boys were because of the oral sex practice in these Western population, and because HPV is transmitted through genital route. So once you are having oral sex practice, then there is chances of having head and neck cancer because of HPV vaccination. That's in countries like Canada and then Australia and some other countries. The boys are also being vaccinated with HPV vaccination for prevention of this oral cancer, which is genitally transmitted.
Discussion about breast cancer before. So I turn to Dr. Acharya, sir. Sir, we've all been hearing that a method of prevention of breast cancer is self examination of any lump. But according to the US Preventive Services Task Force, now self examination does more harm than good. So I think you're the best one who can clear this confusion of ours. So, should we still practice a self examination for breast cancer?
Yeah. So let us see how a breast cancer is being diagnosed. 90% of the time, it is being diagnosed by the patient himself, whether she sees any change in the skin, or there is a lump being palpated, or there is a small lymph node in the axilla or the armpit. So this part is now being taken to the prevention level. So that is why breast self examination has become the standard of doing a monthly once breast self examination just before the menstruation, so that the breasts are not engorged, and you can have the best palpation. And mostly it is done by the patient himself, herself, either in front of a mirror or lying down on the bed. And there are different techniques of going by round technique from center to periphery, and all that. These videos are available in the YouTube. But breast self-examination is one of the most important factors to diagnose breast cancer at early part. But what you are talking about breast self-examination doing more harm is that lot of benign breast diseases also present with lump, and the patient becomes completely, as you know, in United States, people are completely psychophancy about things. They go on reading in Google, they go to the doctor. Till a biopsy is done, they are not ready to accept. So a lot of psychologically trauma goes from the benign lump till the detection and final confirmation. So that is why this has been mentioned. But uh, uh, in India, breast self-examination is one of the most important tool, because all the Western countries, they have a breast cancer screening program where whole of the population are being screened above the age of 40 in most of the countries with a mammogram. But in India, the mammogram is only voluntary. If somebody comes to the hospital, ask for it, then only the mammogram is being done. It is never a countrywide population screening is not happening. So in India, breast self-examination is the only way of doing a population screening by the form of breast cancer awareness programs. So that is why India still utilizes breast self-examination and clinical breast examination by a physician as the screening program for the Indian population.
Little correction over here, Dr. Acharya. I know you didn't mean it, but what has gone to the boys or students is that breast self-examination should be done before periods. Breasts are less. I think it needs activation. It should be done just after the periods, because before periods the breasts are engorged, and
Yeah,
after
correct.
when the
Sorry.
effect is gone, and then only the edema is less, and that's the best time for examining, just after the periods, and then maybe within 3-4 days after the periods are over, because breast is lighter at that time. Initially,
Correct.
just before the period will be heavy, and you will not be able to pick up any lump. It will be painful. Sometimes they are painful also before period. The breasts are painful also. And when Dr. Acharya was mentioning that skin changes and lymph node when it come, although patient might examine, but that is already late stage. What we want a lady to be diagnosed when she is not able to palpate the lump.
Yeah.
And that is only possible through mammography. Because once the lump is palpable by lady herself, then generally by that time it's too late for conservative surgery also. And
no, that is okay, but usually the ladies, they,
instead of coming with a LABC, even if they come with a 1 centimeter lump, that is much better than LABC.
Yeah,
and,
correct. But they should be aware. Yes. Now, even people are coming with fungating lesions.
Yes.
So
no doubt about it. Yeah. Even if they come with 1 centimeter lump, it's better than 10 centimeter lump. With the many times we see. And in fact, if we talk of staging a TNM, then in our patient, the patient don't come in T4, they come in T8 at T10, which probably the staging doesn't exist for that. And the another thing which I just wanted to say, yes, in mammography also, we also have to breast cancer, one such cancer with a strong family history involved. So if the patient is having a direct blood relative suffering from cancer, her mother, her sister, or her mousy and all that, so they are the patients who are at a little higher risk, and they must be made aware by through our health program that they must start doing the breast self-examination at the age of 30. And if they pick up any such lump, they must come to doctor immediately. Generally, we do not recommend mammography before 40, because breasts are generally having a lot of connective tissue, and mammography does not pick up lesions so easily. But ultrasound can always be done. And in cases which we are strongly suspecting an early breast lesion, which is not clinically pickable, then surely in such cases we can do an MRI to diagnose, although MRI is not recommended as a screening. But in suspicious cases, even an ultrasound is doubtful, mammograph is doubtful, MRI is certainly the more confirmatory, although it's expensive. So we do not recommend it as a normal screening process. But in strongly suspected cases, is one of the modality for confirmation. Of course, after that we have that needle guided FNAC and all these things are there as invasive later on. But before that, these are the tests which can be done. Yes,
so to make the things very simple, breast is same mnemonic. Breast is breast nipple discharge or redness, then encrusting or rashes on the nipple, armpit or breast lump, and size or shape changes in the breast, and thickening of the lump, thickening or the lump. So same mnemonic is used for diagnosing any changes in the breast. And the most effective screening is mammogram. But in India, we use breast self-examination as our screening program for the ladies. And if you see, this is what is a mammogram. To make it very simple, it is simply an X-ray of the breast, anterior, we have always two films, that is MLO, that is medial lateral oblique, and epi. So these are the two classical way of doing a mammogram. And there are chances that the lump might appear between two screening programs or two mammograms. So that is called as interval breast cancer. So let us say annual mammogram, and between two mammograms there can be a lump. So that is why breast self-examination is still important to rule out these interval changes in the breast.
Thank you so much, sir.
Cranial and medial lateral, two views. And in heavy breast, then we can have oblique view also.
Yeah,
Craniocaudal and medial lateral.
Medial lateral.
And craniocaudal.
Yeah.
In heavy breast, sometimes it's not possible. Then to see an entire breast in these two views, then you go in for an oblique view also. And it is always supplemented with the ultrasound. Should be supplemented with ultrasound.
Now, always ultrasound is done as a complementary to mammogram.
So thank you so much, sir. I think we got to know the importance of mammogram and self-examination and other screening modalities also. Now, since breast cancer is being discussed, there is one thing which always comes in my mind and which I would...
let me add here, when we talk of screening modalities, besides mammography and perhaps these only look after two cancers, females only. So we talk of, we can't neglect males as well. So
sure, sir.
After 41 must come for annual screening, and that it includes entire clinical examination, will include oral examination, especially ENT examination in our country, because almost 40% cancer head and neck cancer. More so if the person has a habit of chewing tobacco or smoking tobacco, that's one thing. Then chest X-ray, abdominal examination by a physician to see for any lump or enlargement, and then ultrasound of the abdomen. Then a routine blood test, which include a CBC. And since the patient has come all the way, as I said, we can't expect patient to going for cancer checkup somewhere and heart checkup somewhere, diabetes checkup somewhere. So we complete the thing by adding CBC, LFT, KFT, lipid profile, and an ECG. And in high risk cases, especially, we don't recommend cancer markers as a routine screening. In high risk cases, when ovarian is suspected or something else, then we can add some of the screening markers which are there. But the screening markers do not have a role in cancer screening or prevention. They are of value once you have a diagnosed cancer, and linked with that, we have certain markers 53 and 72.4 and 125 and 19.9. So some markers are there. Then CA and ESP also there in some of the cancer which are linked with. But that is only to done when we have a strong suspicion about a specific cancer in a given patient. So then once we pick, then the patient history, the patient is giving history of something with bone pains or something of the sort. So what we are talking of is just to cover up 50% cancer. No country anywhere in the world can do a screening for all 100% cancer. It depends in which area of the world you are there, what type of cancer common over there. Like you go to Japan, where the incidence of stomach cancer and the esophagus is high, they'll certainly recommend for an endoscopy test on the, depending on the patient symptoms. But in our country, this is generally not recommended. So in our country, head and neck is more focused, lung cancer is more focused, cervical cancer, breast cancer is more focused. So our screening methods are much simpler. But in Western population, where depending on what kind of cancer spectrum they have, so all these screening programs are modified and made accordingly. But anywhere in the world, whether it's a USA or Japan or India or any other developing country, whether in Africa or somewhere, no country can afford to do 100% screening for all. Sometimes patient come to us, "जी PET CT कर दो, सबका body का पता लग जाएगा." These are not screening tools. So that method should be there, that you can't use all this. Screening should be with the simplest possible method, which is painless, non-invasive. And only and the breast is your own awareness, patient's own awareness, like in ladies breast self-examination, and in cervical cancer, which is because fortunately more than 50% of cancer in our country, they are either visible directly or within the reach of your finger. But despite that, 80% of patients in our country or 70% patients in our country, in maybe a upper class population, they are coming in late stage. With this is something unfortunate. And many of our cancers are preventable. They can be diagnosed early, and they can be prevented. If they can diagnose early, surely we can cure them early. Despite that, we are losing this advantage. Once we control all these cancers which are preventable, which are curable, it's not that then we'll not have a cancer, but something coming after the natural age of 70, 80, we don't mind, we'll see at that stage. But let's first get rid of these cancers which are so easy to control or prevent or avoid or diagnose early. So this is something which I want all of you to bring awareness to the young generation, and they should pass on the message to all their colleagues, and maybe what other ways and means you have these days. The medal of era of social media is there. So this message, especially for our country, is very important. Is cheapest to diagnose, to prevent many of the cancer in our country. Cheapest to not only prevent, early diagnose many of cancer in our country, and at least those cancer which we are seeing at the age of 40s and 50s, they can be totally eliminated. And let's see what happens after 70, 80, then we'll see at that time. But first, let's get rid of these cancers which are easy to prevent or diagnose early.
Thank you so much, sir. Sir, I think one question which comes in our mind is that we have studied that there are, I think, two vaccine preventable cancers. One of them is cervical cancer, and one of them is the vaccine against HBV, which is
Yes.
given to prevent hepatocellular carcinoma.
Yes.
So, could you tell us more on the vaccine against HBV?
Hepatitis is also one, especially hepatitis B, is one of the risk factor for causing liver cancer. Cirrhosis, alcohol is one of the again predisposing factor which can lead to cirrhosis and liver cancer. And as hepatitis B infection is again which predisposes for liver cancer. And that's why hepatitis B is preventable because of a vaccine. So hepatitis B vaccine should always be taken by everybody in the population, at least those on high risk, like all doctors, all frontline workers with medical professional. You are likely to come in touch with those patients. So all of at least those in non-medical profession, everybody, doctors and paramedical, everybody, they should have hepatitis B vaccine. And all those who can afford to have it, they should have it, because this is something which again is can be preventing you from getting hepatitis B infection and minimizing the risk of liver cancer. Along with that, of course, as we said, alcohol may not be directly related, but still it has almost 3% cancer related to the liver. In overall, we see almost 1/3 because of tobacco related, 1/3 because of lifestyle and diet related, about 7-8% or 10% because of viral infection, which includes HPV, HIV. So these are some of the viruses which are linked with some of the cancers, those specific virus, and about 3% because of alcohol. So it's not that we can enjoy taking alcohol every day. So if at all it's to be taken, it should be occasionally. Moderation, it's fine, but one should not gulp bottles and bottles as people do, and then they don't eat adequate normal food. Indian vegetarian food is the best in the world. Let me tell you that. It prevents you from so many ailments, not just cancer, so many. Maybe the cancer incidence which we are recording low in our country. Now, whether it's actually low or it's fallacious low, I do not know. But one of the factors which could be there are Indian condiments. Turmeric has been found to be preventing for so many diseases in the body. And a big study has been done in US in MD Cancer Center, also done by a very famous Indian scientist who has been listed in the top 100 research scientists in the world, Dr. Bharat Agarwal. He's graduate from BHU, belongs to Punjab, and he retired as a professor in experimental therapeutics research from MD Cancer Center. And he has a huge original research on curcumin. If you just click Dr. Bharat Agarwal's name in Google, you'll find so many papers on curcumin. Curcumin has been seen to be preventing from cancer and from so many other inflammatory diseases in the body, including arthritis. And besides, of course, yoga and these kind of things which boost the immune system of the body, plus good Indian vegetarian diet, not smoked smoked food, because they have a lot of hydrocarbons, of course, which Dr. Acharya was telling. And along that, another risk factor which comes is pickled food also. Pickled food also, achar, it should not be taken that much of a quantity, because they are a rich source of nitrosamines, and nitrosamines are precancerous elements in the body. So these, besides that pickled and smoked food which we have a habit of eating in a country, but otherwise if we have good vegetarian diet, which we call as balanced diet or santulit diet, santulit bhojan, if that is gradually, that's why the most of Western population is shifting over to vegetarianism and restricting alcohol and adding yoga to their life and these kind of things. So cancer is not that dreaded, but we have made it dreaded. This is something which can be reduced to a lot of extent, because the thing which about is not contagious.
So diet and lifestyle are the two very important things that it is in your hand.
Yes. One-third because of that. One-third because of lifestyle and diet. One-third because of tobacco. 10% because of viral infection. 3% because of alcohol. Rest, I do not know.
Yeah.
Maybe
I think Professor Mohan Das from Tata Memorial Center also has a lot of publication on diet and cancer related to GI malignancies. And as I told, MD Anderson did a proper, Dr. Bharat Agrawal did a proper study on curcumin, what is called as haldi that we use. So all Indian spices, there are some Indian spices which are preventable. Like you have garlic, you have ginger, haldi, and some cumin powder like jeera powder. So all these things, lot of things are there which are helping India to prevent cancer unknowingly. Maybe
even mentally also, we are quite a balanced kind of people in our society. All those is now rising, and this solace which we have, maybe is the Sanskriti or Sanskar which we have in our country for ages. By and large, we are more peaceful people, and this peacefulness and a mind, that is a state of the mind, also has a very good effect on our immune system. Because if you have tense in your nature, always hypersensitive, then you are secreting steroids in your own body, and steroids are lowering your immunity. So maybe your peaceful mentality, that serenity that which we have in as part of our large culture and Sanskriti, that also has a lot of positive influence in keeping us away from cancer. But at the same time, because of many of our habits, we are inviting so many other diseases also, not just cancer, but so many other diseases also. Like still people will go on two-wheeler without helmet and get an head injury, which is an avoidable problem in the society, but still they do it. We are so careless in lifestyle. As if we follow whatever culture has taught us since the ages, I think we can be the healthiest people in the world with the longest average lifespan. But somehow we have lost from our track and facing these problems. But I'm sure we'll have to restore ourselves back to our roots.
So again, we will have yoga and meditation as a part of our lifestyle, so that that also will give you, because doing a daily morning walk gives the best antioxidant and oxygen level to your body. So all these things are very important before going for any kind of prevention strategy. As sir told, Indians are also very spiritual people, unlike the Americans, what they did to their democracy yesterday. Indians also so many political parties, but no political party ever has done such type of incidents. So you know there is something called aggression, whereas Indians are more peace loving and more spiritual. So that might be one of the factors why Dr. Grover showed the graph where India is at the lowest of the graph. So, but still, we have a lot to do in cancer prevention, and especially I feel that cancer awareness programs repeatedly among the society, among the students, among the public will also, because people are not knowing what it is. So the more awareness you create, you will definitely get good results.
The first awareness has to be created among medical fraternity, because they also the first person who are able to guide the patients. And that's why these youngsters, when they taken this step, they took it a very positive side and came out all the way to share my evening with them. And then regarding the yoga, which Dr. Rudra was just mentioning, even MD Anderson Cancer Center, they have done a lot of research study adding yoga. And one of the entire academic unit, we have a very good yoga university in Bangalore, S. Vyasa, by the name S. Vyasa. They have a that complete team posted over there, and they have done a randomized control trial of patient on treatment with cancer, some getting yoga, some not getting yoga. And they found a in that one, and along with that they've done a lot of blood tests also in these both these groups of patients. And very good results have been positive results when found in those patients who were also added yoga along with the standard treatment. Yoga may not be able to cure at that time. It may all these things, they have a preventive role, but at the time of getting treatment, they may not be able to cure. But yoga certainly adds to a solace in your body, and your reaction to treatment, your complication of treatment, they become less. And once the complication to the treatment are less, your vomiting or the mucositis problem, if they are less, then patient is able to tolerate the treatment better, and they tolerate the treatment better. The compliance is better, and the compliance is good. Surely the results of the treatment also will be good. So at that stage, once a patient has already suffered from cancer and getting treatment, there the yoga has a role as an additive to the treatment to minimize the side effects and complications. We tried this with homeopathy also. But otherwise, if we take yoga, practice yoga in a normal life, then yoga can prevent us from so many lifestyle related diseases, whether it's cancer, or it's a diabetes or hypertension, or it's peptic ulcer, or it's neurological, psychological problems. So yoga has that much of a positive role on the overall well-being of any human being.
Absolutely, sir. Thank you so much for emphasizing on how we need to be connected with our roots, because now we get a clearer picture of why our culture is so rich and how scientific also, because now, as you have focused on it, that we need to be connected with our roots. Our traditional practices are so healthy that they will eventually prevent us from so many
Yes.
diseases.
So do we wind up? It's
No, no,
No,
sir.
no,
Just so
sir.
many
There
questions.
are actually so
Really.
many questions left, but I
Everybody
think
wants to ask so many things.
due to the time constraint, I think one last question which we can ask. So I would like to inform that we end our segment of screening and prevention here. I think it was really an awesome segment, and we got to know so much about it. One last question of the session, which I would present to all the panelists as an open question. I would ask her that when a cancer patient is in the end stage of the disease and doctors ask the relatives to take the patient back home so that they can spend the last few moments of their life with their family members. So I think it's very difficult at that point for the cancer patient to bear that pain, and more difficult is for the family members and relatives to see them bearing so much of pain. So my question is that is there any palliative treatment or palliative therapy available at that point of time, which can be given to the patient to at least decrease those sufferings at that time?
Yes, certainly it is there. We have so many things. First of all, the counseling of the patient as a family itself, which is psychological counseling. And then many times the patient is in pain, or then morphines are there. We don't restrict giving morphine at that stage when we have nothing left for the treatment. Once we have tried everything and nothing is possible, there's no point in giving pricks to the patient. Many times the family members, they opt out. They say, no, we don't want any more suffering to the patient. We'll take them home and do all this seva for them, whatever is possible. But some of the family members, they say, no, try till the last. And then we also know that in a heart of heart that this patient is, we have tried everything, nothing is possible. The patient is, depending on what kind of problem the patient is having. Otherwise, morphine, the best thing, they'll keep the patient sedated, they'll keep the patient painless, and that is openly recommended all over the world. And then we have certain hospice care center in the country. We have one in Delhi near Subjang Hospital, Shantia Vedna. there they accept these patients which are in end of life stage, where no acute treatment is possible, and they do not have anybody to look after at home, and the family member are not able to take care of them. Then they accept these patients and give them the minimum support whatever is possible, so that what if they have a bed, so they take care of that, so the patient should not die of the septicemia or infection or with maggots and all this kind. So they provide basic supportive facility at that stage in terminal and stage patient. But of course, we do advise, counsel the family of the patients. If the patient is terminal stage, we do counsel them if they can take the patient home, and whatever few days are there, they should be able to help serve the patient at their home. Majority of them they agree. The very few who do not, but then whatever is possible with us, we do that in the hospital, or we tell them, okay, if you don't have anybody else to take care of it, the patient at home, then maybe you can take them to hospice center, which one in Delhi we have is Shanti Vedna. And of course, the end of life is also a very difficult situation to how to handle the family as well as the patient, but it has to be done, because unfortunately in our country, majority of patient, as we said, we are seeing in that stage where cure is not possible in a majority. Like in breast cancer, Dr. Rudra sure said that they stage 3 also you can have 30-40% cure rate, but in other cancers it's not. So in average, we say an average for stage 4 is just 10%. Some like testicular tumor, even in stage 3, 4, we have 80% cure rate. Breast cancer 30-40% cure rate. But in many other cancer like lung cancer, esophageal cancer, stomach cancer, prostate cancer, the pancreas cancer, kidney cancer, when the patient comes in stage 3 and 4, then maybe it will not be even 10% or so. So depending on what kind of cancer the patient is having, what kind of socioeconomic
Yes, sir.
background the patient is having, what kind of the domestic support the patient is having, so then what kind of other problem patient has, which the family whether is able to take care of or not. So we try to train the family also how to take care of the patient at that stage when nothing active is possible medically, and try to give them to that extent. Morphine is freely recommended for such patient, but still if they don't have anybody to take care of, then we advise them to go to this one of the hospice center which we have in Delhi. There is one in Bombay also, the same name being run by the same organization, and pray for the best.
Yes, sir.
Ritika,
Yes, ma'am.
what I want to say is that as far as counseling is concerned, it is a very much an integral part of the cancer management, a holistic part. It starts right from the step that the patient is diagnosed with a cancer. The
Yeah.
entire family and the patient, depending upon their stage, prognosis, type of cancer, site of cancer, is thoroughly counseled, and it is a part of continuum. Palliative care also begins right from the beginning and stage it so that they are all prepared mentally what they are going to what will be the prognosis and what they are going to face in years to come. Some cancers
Yeah.
become past history. Some cancers will have a very steep downhill progress, like gallbladder, ho gaya, pancreas. Some cancers really are managed well. So it's very much a part of the whole thing right from the beginning.
Very
Yes,
true.
ma'am.
Because cancer normally requires a long treatment, long term treatment, which you have to undergo so many diagnoses at repeated stages. Every treatment has to follow the other one, that the complication side effects would be there. So patient and the family have to be prepared in advance
Every
for a
step.
long downward treatment, for all the kind of treatment. They have to shown that roadmap. So it should not come to a surprise. They have to also have to be told that we are doing this, and with this kind of treatment, this much of result is possible. We can't expect 100% cure rate. We have to tell them this is the chances, and probably you might need something else also. We wish that you don't need it, but you might. So you should be mentally prepared for that, for those kinds of treatment in the pipeline, or maybe sometimes the cost factor also. So all these things have to be explained to the patient at every stage. I said, Dr. Meeta said, right at the moment patient comes to, you have to give them the roadmap which is likely to be for the treatment, likely lifespan, which is called as predictive oncology. And these days, with the modern things coming up, a lot of things are being based on molecular oncology, on genetics and these kind of things. And many times on the basis of these genetic tests and gene sequencing and all, we can have a better prediction about not about the prognosis, but also we can choose a specific targeted treatment also for these patients. If you have
Yes.
some of the genes sequencing on certain specific gene defect which you can pick up, or gene mutation or amplification or deletion, then you have some of the drugs which are specifically available those against those kind of defects, which like in CML, chronic myeloid leukemia, which a few years before it was not treatable. Now these days, once you have the gene defect available, if you can find it out, then you have just simple drug which one has to keep taking lifelong, and that good enough is keep the patient under cure. So the things have improved greatly over the years, but what we have to do is much more than what we are not doing now. And that much more is try to prevent cancer which are preventable, try to diagnose cancer which can be diagnosed early and treat them, try to augment the treatment facility, which I told you. If we have diagnosed the patient in early stage, we must be able to treat them also in early stage. The waiting period should not go on for months and months when stage 1, stage 0 becomes stage 1 and stage 1 becomes stage 2 and 3 or 4. So then the whole point of early diagnosis becomes a waste. But as I told, the gap which is we have now in a country between the cancer patients available and the facilities available, that gap is widening in the over the years, because we are not adding that many facilities in the country. So we have to act on many directions parallel:
Friends.
awareness, prevention, early detection, and augmenting the facilities or treatment. And for the facilities treatment, these days so many modern modalities have come, so we have to think of that also. As I told, this is a country where you have bullock cart also, you have to rocket also. You can't
Yes,
wait for things to come in series. You have to act in parallel, because you keep acting in series, you'll always have a wide gap. And these world has already gone so far ahead, we have to catch up at much faster pace than what they are doing. We have to be faster, so that we somehow we are able to match them in the near future. May not happen 1 year, 2 year, 10 years, but maybe like next 15, 20 years, we should have that roadmap available with us and act accordingly. And that's why I said the future lies in your hand, because you're the future generation of the country. So you should be more energetic and more aware about what is required. We can only guide you at this stage, but you have to take the mental, and wish you all the best for that.
thank you
And
so much, sir.
doctor,
Yes, ma'am.
you all have done a very good job, and it was so innovative. And really, Ritika, must and the Dr. Imam, your friend, colleague,
Yeah, Zainab.
you both have done wonderful job. Really, I'm quite impressed.
Thank you
Bye,
so
Iman.
much,
Yeah.
ma'am. Thank you so much, ma'am. That's really kind of you. And I think Zainab wants to say something.
Sure, Zainab, most welcome.
Indeed, been a very informative and highly interactive session, and we have been bombarded with doubts with so many of our participants. But due to time constraints, we won't be able to tackle all of them. But I would just request you to answer a few questions, which some of them have asked.
Please wind up.
So, if you give me permission, I would like to start with the first question that has been asked by Fatima. So she says that nowadays, after hearing about cancer from friends and relatives, people are in a habit of looking it up on the internet. And she says that I personally feel that Dr. Google is not always reliable.
Never.
So I want to ask you that how does a common man filter out information? How do we prevent ourselves from believing in information that is false and unreliable with regard to cancer?
You can't. You can't depend on Google, because if that is so, then probably you don't need hospitals at all. The medical profession doesn't come from classrooms. It comes from your practical experience, which you learn from your seniors and goes down to juniors. Books are only there to guide, but the real experience come to you from your seniors. From the is a guru shishya parampara. You can't read from the book and start examining and treating a patient from tomorrow. And Google can only add to confusion. Maybe okay is making the patient aware. The doctors have to. The only thing is we have to become more conscious that patient is coming with half-baked knowledge, and that half-baked knowledge is dangerous, and we have to be one up above them. And that means we have to keep in touch with Google also and our own literature also, and tell them, okay, this is what you're reading. Google is just giving a vague idea about the things, but every patient is a different patient. Even what your book is telling, book is giving you a huge knowledge, but that whole knowledge doesn't apply to every patient. Every
Yeah.
patient is an individual patient.
Absolutely,
Even we
absolutely.
can say that the same T1 N0 M0 patient of breast cancer or tongue cancer, oral cancer, whatever it is, but every T1 N0 M0 is not the same. Despite the fact their treatment, they are doing the same, results are not the same. I said in stage 1 you can cure 90%, that 10% we are not able to cure. Then who are those 10%? Who are those 90%? We do not know. That is something which is inherent biology of the patient. Maybe with these days gene sequencing methodology and molecular oncology methods available, we might have a better prediction about who are the patient who are curable, who are the patient who might not get cured. But still, we are not 100% sure it's even till now. So every patient is a different challenge for us, especially in the field of cancer. And every patient we have to monitor. That's why in the entire history of the patient, how the patient presented, how he or she responded to the treatment, what are the side effects or complication, how much period was there which was disease free, when did the disease replace in a particular patient, what was the intervening period of disease free period. So all these factors are important for us to ultimately decide the next line of management. So Google is there to confuse the patient, it's fine, but we have to bring them back to the track that okay, you have said enough what you wanted to listen to us now. So of course it takes a little more time for us to counsel the patient and draw him back from the Google. But okay, we have to face that also challenge. Google doctors these days are very common. So we have to know what is happening in Google, and we have to know what we are supposed to do.
Absolutely, I think very correct, and I think we have to recommend people to stop relying so much on Google, and because half knowledge,
They'll still do it. They'll still do it. We
they
have to be
still do
prepared.
it. Yeah, because half knowledge is way more dangerous than
How many people jump
having
at night to the
nothing.
traffic signals? How many people go without helmet on their two-wheelers? So people will still do it. We have to, many times people coming from the wrong side, you have to prevent yourself. You can't say, no, I'm right, so I'll hit you because you're on the wrong side. You have to take precaution and prevention.
Yes, absolutely.
So let's find out.
Uh,
It's a long time.
yeah. One more question, I think, sir, because it was asked by around 10 to 12 students. I'm getting those questions again and again, sir. It's just one last question.
Sometimes again, sometimes later.
Yeah, just one last question, sir. That they had also given me examples that very famous actress, I think we all know that Angelina Jolie has done a preventive double mastectomy and
That
salpingo-oophorectomy
is over.
because she had a
That is an over.
family history of breast cancer.
Yes,
So I think what,
that is an overreaction.
okay,
One should not do it. You
okay,
because everybody has it. Then you can't just keep chopping off breast and uterus and cervix of everybody.
true.
Fair enough.
But technically, it is a BRCA1 disease where breast
Yeah,
ovary both are very common,
Yes.
and she had incidence wise her Masi and matlab 2 or 3 family members were BRCA1 positive, and she was
yes, yes,
herself
yes.
BRCA1 positive. So it is totally voluntary. It is not
Yes.
completely recommended. Maybe it is a voluntary. It is a decision taken by her.
But little overreaction, too much apprehension.
Yeah.
One could have gone for a routine closer screening, and maybe still would have been the same. Because many times, a preventive surgery doesn't really help that much if you are otherwise doing it. Like you say, many of the block dissection you do it. If you do it at prevention or at prophylactic, or do at the time of presentation of the lymph node, the survival doesn't change. So sometimes it was little overreaction. Maybe it could have been avoided. And that in fact sends wrong signal to everyone in the society. Everyone will say, I'm BRCA positive, remove my breast, remove my cervix, remove my ovary, remove my uterus.
Yeah, I think
One has
that
to be
makes,
logical and little more, that is why I say stable mind.
yes, sir.
She'll not become immortal by getting all these things removed.
Yeah, absolutely. I think that makes it very clear. And as we all know, that this is a never-ending discussion which can go on and on because there is no stopping in the path of learning, especially when we have such eminent people with us. But we have to end the session here due to time constraints. So, nevertheless, I'm sure that it was one of the most amazing and knowledgeable sessions we have ever attended. I would like to give our heartiest and sincere gratitude to all our honorable panelists on behalf of the whole Games team to have given their precious time and pearls of knowledge and wisdom to all of us. Thank you so much, sir and ma'am.
Thank you so much, all youngsters, and keep it up. And thanks a lot for coming out with such an idea. And wish you all the best in your career always.
So
Thankful to you because you guys are living examples of how a good doctor cures the disease, but a great doctor cures the cause of the disease. So,
Exactly.
Yes, thank you. Thank you.
So thank you very much. Keep spreading the cancer awareness as far as possible.
Yes, sir.
but
Thank
all
you.
of you, we have
Okay.
been blessed to have you with us. And a big thank you to our audience as well for joining the session and being so inquisitive to know so much about cancer. So let's wrap
And
it up.
any rest of the questions, you can put it on mail. We will love to answer.
Correct. Exactly. Correct.
Absolutely.
Very
Oh,
true.
that would be wonderful. That would be wonderful. We'll
That
convey this message to the audience. They would be enthralled to get their questions answered by you all. So we'll put it up and so that we can revert back to you with all the questions then.
Thank you very much.
All the
Thank
best.
you.
thank you so
Thank
much, sir.
you.
Thank you,
Good
ma'am.
night. Good night, all of you.
Good night, ma'am.